we are a little early, which is great. That gives us some more time, and there are questions. What I do not know, since we are not meeting in person, is who of the other presenters, the other faculty, is in fact online right now to address questions. Lee, or do we?
Yes, Dr. Deeg, you have yourself, Dr. Keel, Dr. Kamarachi.
Okay, good. So there are,
and Costa and
yes,
Costa. There's
yes,
the 4 of
thank you. So let's see, there are several questions. One related to, well, let me catch up here with the question. Sorry for that. Yeah. One question here is, can you give G-CSF the same day as Vidasa? Question mark. Do you give prophylactic antibiotics or antifungals for severe neutropenia? Maybe Dr. Komroki, do you want to respond to that question?
Dr. Kamarachi's on mute.
Well, I also don't see
so
him.
hang on.
Okay, maybe we can.
Yes, let me see if I can reach him.
All right. There is another question again, probably most appropriate for him. Well, there was one regarding mutation I thought we'll have. Oh yeah, let's go back to this one. Is there for Dr. Keel, is there a blood test to determine if a patient would respond to immunosuppressive therapy? Do you think from as far as genetic, I think actually Dr. Mal, he touched on that very briefly, who is likely to respond, who is not likely to respond with his bone marrow failure states to immunosuppressive therapy. Any comments from you?
Yeah, I would just ask, so I think what the question is, or I'll kind of rephrase the question to make sure that what I'm answering is what's intended.
Right.
But if a patient presents with what we use the word marrow failure kind of loosely, but when we use the term marrow failure, that basically means the bone marrow can't maintain normal blood counts. And I often clarify that a little more and say, are we talking about a hypocellular marrow failure state? And what I mean by that is that you don't make blood counts appropriately. And if you look at in the marrow, the cellularity of the marrow is low. There aren't as many blood cell parents that you would expect normally to see. And so in the context of a hypocellular marrow failure, we always ask, is that immune mediated or is that an inherited cause? And the question is, gosh, are there any clues you can get that support more strongly that it's an immune mediated aplastic anemia? And I would say the two indicators that, and I'm not going to say they're 100%, but they're looking like they're very supportive of an immune-mediated marrow failure is one, when we look for, if we find the presence of a PNH clone. And if you remember from Dr. Scott's lecture earlier, we detect that PNH clone in the peripheral blood or in the bone marrow by a test called flow cytometry. And among patients with immunologically mediated aplastic anemia, a PNH clone is present in some place around 30 to 40% of patients. And that is very supportive of an immune-mediated aplastic anemia. The second that is a little more nuanced and is only present in about 10% of people with acquired immune-mediated aplastic anemia is a particular chromosome change that requires a specific way to look at the bone marrow. And I mentioned this way to look for mutations in my talk, which is called an array. An array is done on the bone marrow, and that can detect a certain change I'm going to use a fancy word here, but I'll come back and explain it, called copy neutral loss of heterozygosity. So think of that as a change in the chromosomes that you're not able to detect on a normal karyotype. And if you see something called 6p, copy neutral loss of heterozygosity, that also is emerging as pretty supportive of an immune-mediated aplastic anemia. But again, it's only present in about 10% of those patients. So the absence of it doesn't tell you it couldn't be that.
Okay, thank you very much. Dr. Komorocki, maybe a couple questions. Yeah, definitely a couple questions for you. Here is one. Let me read part of it. My husband was diagnosed with intermediate MDS in February after 3.5 dose pack, I suppose, of Incovy. His hemoglobin is rising well. However, his WBC and neutrophils are very low, but increasing very slowly, and presently taking 2 prophylactic antibiotics. Treatment has been halted after the second marrow test. Is this normal? First question. Are there any new studies for bone marrow transplant for very healthy 79-year-old men with longevity genes? With the treatment being halted, does this mean the 5% blasts are increasing? So it's a long question, but the bottom line is, why on Incovy, yes, getting better as far as hemoglobin is concerned, but the treatment has been stopped. There may be a number of reasons, but do you have a comment?
Sure. So I think obviously it's mentioned that the patient's intermediate risk. Obviously, like, I think it's important to know why the Incovy was started. Was it just anemia, or it seems that their blasts were increased? So it seems an appropriate treatment. It's an oral regimen. Myelosuppression, which means reduction in the blood counts, is very commonly encountered with those medications, particularly neutropenia and thrombocytopenia. I would say also in our experience, we've seen a little bit more with it with the Incovy, even more than what we see with the IV Dacogen. So I think to mitigate that, as mentioned, sometimes the doctors may delay the treatment a little bit. Sometimes if the patient is receiving 5 days of the Incovy, one would consider the 3 days rather than the 5 days. But it depends on the context of different things. But yes, like myelosuppression is common. And sometimes what we see, even if there is like a response in the anemia, that the platelets and the neutrophils will hover around the lower of the normal. They will not go back to the original baseline. In terms of the question of the transplant, I think obviously, as Dr. Scott mentioned, age per se is not contraindication. We look at the age as function and comorbidities, but you have to put it in the context of the margin of benefit also. Somebody who's 79, intermediate risk, may have a survival of somewhere 3 years or plus. Those are averages, nothing, but, and then what's the margin of benefit from the transplant? And right. I try to have it in that term of discussion with the patients. I individualize with them, what's the margin of benefit? Somebody who's 79, their margin of benefit may be only a year or 2 at the end. Weighing that against the quality of life may not become the most, appealing decision to proceed to transplant directly.
Right. Yeah, I agree, if I may, and I just submitted a paper actually looking at some of those questions. I think if patients otherwise, as emphasized here, seem to be in good shape, I think nobody is very healthy if he has a leukemia or MDS. I mean, it's sort of, we ignore that sometimes. But if a patient is in good shape, good condition, I think should have a consultation. But I would stop short of suggesting should proceed to transplantation. I think those are difficult and individual discussions. There are several other questions. Let me see whether I can summarize one also for you, Rami. Do you give venetoclax and hypomethylating agent as outpatient? Go ahead.
Right. So first, like as I mentioned, like I will not advocate using them liberally till we see the final results of the trials in MDS. In AML, they are standard of care. They are approved by the FDA. So in the AML, yes, we do them as an outpatient setting. We actually looked recently at our data, and like we even, have seen almost 0 tumor lysis. Doing them outpatient doesn't mean that those treatments are not intense. So I think the message is that those treatments are good. They are somewhere like in between the intensive chemotherapy and the Vidasa. So you could get them as outpatient, but I think there should be some expectations that the patient is going to be following on regular basis. There will be need for supportive transfusions. The blood counts are going to be very low. We may need some antibiotics, and there should be a repeat of the bone marrow or the assessment early on, like after a month, because most of the time, if not always, like we have to back off those treatments, give a break or holiday for a week or two to allow the counts to come back. If there is a fever anytime, the patient has to come into the hospital. So yes, they could be done outpatient, but with very close observation. In MDS, I would say they are like still mostly investigational. Obviously, every now and then we've used them. But
there is a question somewhat related. Let me just chip it in. Can you give G-CSF the same day as Vidasa, along with Vidasa?
We usually actually try not, we don't do much G-CSF at all. Like obviously G-CSF use in higher risk MDS is very controversial. Some studies suggesting it may increase the blasts, and then the benefit is not clear. I personally restrict use of G-CSF unless somebody came in with febrile neutropenia, very sick, pneumonia, cellulitis in the hospital, a very short course of it. I don't do primary prophylaxis, which means giving the growth factors just to prevent the neutropenia or the fever. I would rather, if somebody's neutrophils are low, use prophylactic antibiotics and not use growth factors along with the hypomethylating agent.
Right, thank you. Chopin, Dr. Keel, briefly, if you don't mind, I had tried to address it briefly. Will you routinely send blood for PNH in a young patient with unusual thrombosis, even if CBC is normal and there is no evidence of hemolysis?
Hi, that's, that's a good question, you guys. I wouldn't say I have an absolute around that. I think more commonly, if I see thrombosis in unusual places, and when I use the word thrombosis in unusual places, that's oftentimes abdominal clotting or sometimes clotting in the brain that's not explained. And that literature came out a number of years ago that if you look among those individuals, a percentage of them actually have a myeloproliferative disorder, not PNH. And so I'll actually send in thrombosis in unusual places that aren't explained a JAK2. And so I'll look for an undiagnosed polycythemia vera or an ET. Right. And I would say I reserve the PNH. I kind of think about it a little bit. The clotting in PNH is thought to be related to the hemolysis. And so you would expect to see also markers of hemolysis. So those are labs like something called an LDH or other things that are saying you're breaking up.
You're saying it is unlikely that they are completely disjointed.
Exactly.
Yeah. Let's see, here's a question. Maybe I will try. When hypomethylating agents fail and the transplant is not an option, how long is it safe for a patient to be transfused? Again, any one of you probably can answer or wants to answer that. If there's really no other option, we will transfuse the patient as long as possible. And with red cells, that is usually not a big deal. But as Costa Herbert just said from her nursing perspective, I think these are situations where certainly palliative care is a very important component and should be part of the management of that patient. Do you want to add something to that, Costa?
No, I think that's absolutely the road. I would say is at some point as the medical team, we have to look at all of us and the patient's part of that, the risk and benefit versus quality of life. And so I think that's definitely appropriate.
Now, there is a question addressed to Dr. Scott, who, as far as I know, however, is not with us live. I will try. When is developing GVHD no longer a concern for transplant patients? Very good questions. GVHD is really a continuum. You can develop GVHD as early, that was not the question, but as early as 10 days after transplantation. And we see occasionally a patient who develops a more chronic form of GVHD as late as a year or even 18 months after transplantation. That is not common, but it does occur. So we continue to monitor patients or ask patients to self-monitor carefully for an extended period of time. We had, let's see, can you combine gabapentin and duloxetine for neuropathy post-transplant? I suppose you can, but I am not sure I have a set of data on which I can base my answer, quite frankly. We try to, most patients after transplant are on lots of medications anyhow. So we try to simplify the management to whatever extent we can. And because whenever we add another drug, there are multiple additional interactions that occur that are sometimes very difficult to predict. Here's a question, maybe again, Rami, you can address it. I think it's, can a patient switch to Inqovi who is currently using Decogen? If so, what is the process? What would be the benefit? I think that's the important part of the question.
Right. So yes, I think it could be done. So as I mentioned, the oral Decogen or Inqovi is almost 100% bioequivalent to the IV. Right. So I think one could shift. It would be with the next round of therapy. I think one thing to mention as logistically important that, sometimes we've faced issue with the copay. So this is an oral pill that has to go through the insurance, and the copay can be an issue with it sometimes.
Yes.
The treatment is given the same 5 days. Sometimes the doctors may elect for 3 days. So it's only given 5 days and you get break again for 3 weeks. It's exactly like the IV Decogen. Right. And you shift. The studies looked at shifting patient like after the first cycle in between, and it should be bioequivalent, but again, does not eliminate the need to monitor blood counts in between or based on the transfusion needs. But yes, it's doable. I would say double check the co-pays because that could be an issue, and then the safety is the same.
There's another question. Isolated mild neutropenia, mild, or isolated mild thrombocytopenia is very common in the general population. What is the incidence of MDS in this situation, and how can we avoid sending blood for NGS in this many patients? Well, I will try to give a very partial answer and then invite everybody else to chip in. I mean, we mentioned, I think, yes, in response to another question previously, there are certainly, let me just call it precursor stages for the development of MDS, and the presence of a single lineage cytopenia may very well be one of those. Most often it is red cells, but in some, I would say 20–25% of patients, probably neutropenia or thrombocytopenia. So it deserves, I mean, we call it next generation sequencing, but in a way we have already moved on. I mean, the next generation is behind us, so to speak. In other words, the sequencing and mutation analysis is part of the clinical workup of those patients. I see that Kanwal has joined us too. Do you have a comment on that?
Oh, sorry, I joined in late, Joachim. Could you just comment on
the question was isolated mild neutropenia or thrombocytopenia are very common in the general population. What is the incidence of MDS, and how can, that's what I'm focusing on right now, how can we avoid sending blood or NGS orders in this many patients?
Yeah, I think I agree. I think, it's if there's other clinical history or family history or something, I think that makes sense to consider looking into these markers a little bit more. But I think also just long-term severity, just watching it over time. But I do think that we're going to get into the range at the age of wanting to send off more as our patients, as the medicine evolves. So
let me have a look. There are also a couple comments in the chat box. Why don't I? Oh yeah, that's why I don't see it. What was it here? Okay. My husband is on venetoclax and in remission. What is the overall outcome? I suppose this is a patient with MDS, although that is not stated here. Rami, do you want to try and answer to that?
Sure. So obviously, as I mentioned, with hypomethylating agents, even with the venetoclax, those are treatment, not cure. So unfortunately, at one point, we will see the treatment stops working. What we know from the AML data, that the duration of response of the combination was a little bit longer than AZA alone, somewhere approaching around a couple of years.
Right.
But it depends on the depth of the response and all that stuff. I'm sure they probably backed off using a little bit the venetoclax, which is okay. Sometimes, like once you're in remission, you can a little bit cut down on the venetoclax. So I would say I would expect more than what we see the average a year with the AZA. But at one point, it is going to stop working, and we see the blood counts dropping down. The phase 3 trial is still ongoing. We will see the survival data in the MDS patients. From our database, when we look at it, for me, like also one of the areas we've seen some benefit from the patients that we treated is like if they got into response and went to transplant. Our own data looking at AZA-VEN going to transplant in MDS is almost like 90% 2-year survival. So this could be also an option that Dr. Scott mentioned, that in trying to get better preparing regimens for the transplant. So again, if the patient is candidate and good shape and young age, the fact that they are in remission does not exclude the consideration of the transplant as well.
Yeah, in fact, and there's another question which relates to that. My husband has started INCOVI, diagnosis MDS, EB1. Is there a standard amount of days before transplant is considered? And in follow-up of what Dr. Komrokic has said, I think there are numerous parameters that we are looking at, but our general recommendation is if a patient is responding to hypomethylating agents, one should, and is a transplant candidate and otherwise would fit that mold, one should proceed to transplantation as long as the patient is responding. But as I think Dr. Komorgi did point out before also, if the patient is not a transplant candidate, or Scott said it, I forgot now, then we continue as long as there's a response, as you just said. Let me look one more time at the question and answer box here, and then maybe we'll take. How are patients monitored for GVHD? What tests are done? That's a big question. Trying a simple short answer to that. We monitor patients, or ask the referring physician who is seeing the patient to monitor the patients very closely, and the patients get detailed instruction to monitor for anything that is changing. I know dry skin after they leave here, dry eyes, evidence of malabsorption. I mean, their stool pattern changing, mucositis, really a total body observation, if you wish. And if there's any, and chemical test, of course, liver function test in particular, if there is any such finding or symptom, then they should be completely evaluated to get the cause. There may be other reasons, but if there is evidence supporting the clinical impression of GVHD, then one would have to initiate treatment. Anyone else who wants to chip in? If not, well, let me see. There is one more for Dr. Komrokian. What clinical trial are you most excited about for MDS?
All of them. So,
all of them, okay.
Yeah. So, but I think the reality, as I mentioned in my talk, that the landscape is changing, and there are several promising drugs. I think one of the principles I always talk to patients is like, obviously nobody should promise a patient a better response going on clinical trial. That's why we are doing the clinical trial. So that's a must. But obviously trials do help patients and help all other patients. Many of the studies I mentioned are in the phase 3. So it means, all the patients will get a treatment. There is no placebo. So either you'll get the standard of care, which are like hypomethylating agents plus something else. So in the higher risk, we mentioned venetoclax data are, interesting. There is the magrolimab drug, sabatolimab, pevindostat, like 4 drugs in the higher risk MDS in advanced stage of testing. the emtilistat in the lower risk MDS showing activity. So it's really a good time for clinical trials. And I would say like, that's always my recommendation, is to strongly consider a clinical trial upfront, whether it's in the context of transplant or not, because even going on clinical trial for upfront treatment does not exclude transplant. So I'm excited about all of them, and I'm hoping that they will really translate to more options for our patients shortly in the near future.
Excellent. All right, why don't we at this point
Dr.
take-
Deeg,
Yes,
real fast, we had a couple of questions that were earlier that we put on hold. Do we want to ask Dr.
No, I
Camarachi
lost-
those real fast?
I hear you, but I don't see you anymore. Hang on.
Do you want me to go ahead and read them?
Well, yeah, go ahead, please.
Okay. This says, I was just diagnosed with MDS EB1 and will get DNA testing on Tuesday. What would be some of the most important questions to ask?
Oh, we did address that one.
Did you already do that one? Okay.
Yes.
And then, can you have PNH with anemia only, not pancytopenia?
Anyone wants to answer that? Dr. Keel or Dr. Mali?
Sure. Yeah, so I think the question was, can you have PNH that only presents with anemia and not pancytopenia? And absolutely. So we kind of, if you remember that everyone shows that Venn diagram of the overlaps between MDS, aplastic anemia, and PNH. There is an entity of classical PNH, and classical PNH we look at as just the hemolysis component. And sometimes folks can have a little bit of cytopenias with it too, but it is not a requirement that the other blood counts are down. The anemia is from an absence of those proteins on the red cells, and that's a red cell specific manifestation.
Right. Okay, thank you very much. We'll take a brief break here and reconvene at about 1:30 our time, if everybody agrees, to continue with our presentations and subsequently one more discussion for those of you who are still online. Thank you very much so far.
Thank you.
Thank you. Have a good day.
You too.